going to talk about adverse drug events, the FDA monitoring, and as well as the some clinical studies and the basis of those. So first of all, we will define what is known as an adverse drug event, which is often referred to as an ADE. Many times it may be called an adverse drug reaction, which is an ADR. But basically an adverse drug event is any injury resulting from medical intervention related to a drug. And this includes not only the side effects associated with the drug, but it also includes any errors associated with giving the medication. Basically, an adverse drug event generally is going to be an extension of the pharmacological effects of the drug, so it's usually pretty predictable. So what we see is a number of these adverse drug events that we've identified as on slide 69. So the augmented pharmacological effects would be that we get too much of the drug's effects. So for example, if I were to be using an antihypertensive drug that's intended to lower blood pressure, an adverse event may be I get too much lowering of blood pressure. If I was using an antidepressant to increase or elevate mood, I may get too much elevated mood and I may push the person into mania. So these are pretty predictable based upon the pharmacology of the drugs. The other type of adverse events we get are basically what is referred to sometimes as the bizarre effects, or what some people call unpredictable effects. These are called idiosyncratic reactions, and these occur at any dosage and usually involve the immune system. We can also have chronic effects versus acute effects, so that a person may be able to handle a drug on a short-term basis, but as we prolong the administration of the drug over weeks, months, that they may develop other effects associated with the chronic use of the drug. We may also have some delayed effects where that we give the drug and then it may be several hours or even several days before the effects may show up. And then we also have to consider that, especially with many of the drugs that you might use, and also a lot of drugs that are used for pain management, is we may have end of treatment effects, things like benzodiazepines, even some of the antidepressants, whereas when the drug is withdrawn, basically we have a withdrawal reaction. So these would all be considered adverse drug events. Slide 70 actually gives us the definition that is used by the World Health Organization, and it basically talks about any effect which is noxious or unintended, which occurs at doses used in man for prophylaxis, diagnosis, or therapy. So this basically includes any therapeutic use of a drug and the side effects associated with it. It does not include, for example, if someone does an intentional overdose for suicide, that would not necessarily be an adverse drug reaction. However, the possibility of the drug producing suicide ideation could be a drug side effect. And what I have listed on slide 70 is the two major types of adverse drug reactions, type A and type B. Type A is the most predictable. It's dose related. It's usually an exaggerated extension of the primary or secondary pharmacological activity of the drug. It's a very predictable type reaction. Type B is those more unusual, the idiosyncratic reactions. And this generally is going to involve the immune system or an allergic reaction. And generally it is independent of dose or route of administration. What I mean by that is generally the issue becomes that it'll occur at all of the clinical doses that are used, and it doesn't really matter as to whether the drug is taken orally, given by injection. These reactions can still occur. Talking about drug allergies, let's touch on drug allergy or hypersensitivity reactions in the next couple of slides. On slide 71, we see the type 1 drug allergies. These occur pretty immediately after administration of the drug. It will include anaphylactic reactions. This is mediated specifically by immunoglobulin E. And basically, most of the effects are due to the release of histamine, prostaglandins, and other substances which then produce the immediate anaphylactic reaction. A type 2 reaction is considered a cytotoxic hypersensitivity. Generally, there's antibodies that develop, and the antibodies attack the body's tissues. For example, the antibody reacts with the antigenic components of a cell, And one example of that would be a drug-related effect called a Coombs positive hemolytic anemia. This can occur with a drug such as methyl-dopa. And what happens is that the antibody attacks the red blood cells because of the expression of an antigen on those red blood cells, and it destroys the red blood cells, causing the hemolytic anemia. Slide 72, we have the type 3 reactions. What happens here is that there is these circulating antigen-antibody complexes that get deposited on the body's tissues. This can be in blood vessels, this can be on other tissues, and we see these examples of this would be what is called serum sickness, or there are drug-induced lupus syndromes. Rheumatoid arthritis is a form of this. It's really not a drug allergy, but is a type of allergy that occurs here. And finally, the type 4 drug allergies. These are generally cell-mediated. They're sort of delayed reactions. We have the sensitized T cells, which are immune systems. Antibodies do not appear to be involved, and this would be things like occurring with contact dermatitis. So basically what happens is the T cells have to be activated. This is why there's this delayed reaction, and it's called cell-mediated because it involves these T cells. So those are the 4 major types of drug allergies that are identified pharmacologically. Now, one of the things, because you will be dealing with patients that may have drug allergies or hypersensitivities, the clinical criteria for a drug allergy or hypersensitivity is actually identified here on slide 73. And what's happening here is basically we identify a drug allergy or hypersensitivity is that the person is generally prior exposed to the drug. The person often may not be aware of that initial exposure. They may not remember being exposed when they're younger or something like that. Generally, there's this period in which sensitization occurs. We see that once the criteria, or once the allergy bases or the precursors are set up, then an exposure to the allergen, to the drug, can occur at any dose. And what we often see is if we look at the histology, we will see that there's a lot of eosinophilias, which means there's a lot of eosinophils that are present in the tissues and even in the blood. We may even see that in a blood sample. We can see the eosinophils increased there, and that's an indication of a particular drug allergy. The other thing about it, as indicated on slide 74, is often the symptoms will subside after the drug is discontinued. So this is sort of a D challenge. If it's drug-induced, if it's a drug-induced autoimmune reaction, it can continue because it sets the immune system into play there, and that can result in a continuation of that. What we often see is that there is often a re-challenge with the drug, and that can initiate a similar pathological involvement as we saw initially. Now we're going to change directions here a little bit on 75. We've talked about adverse drug reactions, and now I want to sort of put this into perspective how this gets integrated into the clinical information that's provided in the package insert, and we're going to also talk about or move into how a drug is approved with the FDA. In the United States, we have the National Adverse Drug Reaction Reporting System. Drug manufacturers, as indicated on slide 75 here, are required by law to basically report all adverse drug reactions to the FDA. This has become increasingly more important because the drug approval has sped up. And generally, the FDA wants any reaction to a new drug, and they define a new drug as one that's been on the market 3 years or less, needs to be reported regardless of what it is, whether it's on the label already or whether it's depending on how severe. So if a person gets nauseous with a drug, that's not a severe reaction, but ideally they would like to see that reaction reported to the FDA. The FDA is particularly interested in any unexpected or serious reactions. Unexpected, as on slide 76, would be the any reaction that's not already on the label. It's something that we haven't identified. And that's actually true for any drug on the market as it stands now, whether it's a young drug or just came out, or if it's one that's been on the market for 30 years. Now, when we talk about severe definitions, the FDA has specific definitions for this. I've got these on slide 77. A minor reaction would be where that pretty much there's no antidote therapy, no reason to prolong hospitalization. This would be, for example, a person gets nauseous, okay, gets a little queasy stomach, nothing really has to happen, doesn't really create any major problems. A moderate one would be that there's a change in therapy. We have to put specific treatment in there, or that hospitalization is increased by a day. So using our example of nauseous, let's say the person gets pretty nauseous, where that it is, they feel like they're going to throw up. It is making them very difficult to function, and we might have to either discontinue the drug, or we may have to give them something to handle the nausea. A severe reaction can be potentially life-threatening. Generally, requires a permanent change, or it may cause permanent damage if it's left unaddressed. The person, using the example we have, the person gets nauseous, the person starts vomiting, maybe gets some diarrhea that gets to be pretty severe. That would be a problem that would be considered severe because of the potential for electrolyte imbalances occurring. And then obviously a lethal one would be anything that may directly or indirectly contribute to the death of the patient. So that would be what we're talking about there.